Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from India, Professor Ali Asghar Moyadi. Prof. Moyadi is the professor and consultant neurosurgeon and chief of neurosurgery at the world-renowned Neuro Oncology Center, Tata Memorial Hospital, Mumbai, India. He is an expert and world-renowned neurosurgeon specializing in neuro oncology. He is the joint treasurer of the Indian Society of Neuro Oncology and is also on board of the Executive Council of Neurological Society of India. He is also the section editor of the World Neurosurgery, and he is a very well-known author who has published several articles in various reputed international peer-reviewed journals. We are extremely honored to have him today at the webinars, and today he will be talking about intraoperative ultrasound in neuro-oncology, low-cost, high-efficiency strategy for global neurosurgery practice. The speaker for the second session of today is our honorable guest from China, Professor Xu Ming. Prof. Ming is the Associate Professor in the Department of Neurosurgery at the Huashan Hospital, Fudan University, Shanghai, China. He is an expert in the skull-based surgery and is also a renowned author with several publications in various peer-reviewed journals. We are extremely honored to have him today at our webinars, and today he will be talking about microneurosurgery for hypoglossal schwannomas. The chair for the first session of today is our distinguished faculty from Italy, Professor Cecilia Casali. Prof. Casale is the head of Brain Metastasis Unit, Deputy Chief of the Neuro-Oncological Division, Fondazione IRCCS, Istituto Neurologica Carlo Besta, Milan, Italy. With over 2 decades of clinical and academic experience in neurosurgical oncology, she has dedicated her career to the advancement of surgical technique for brain tumors, the integration of intraoperative imaging, particularly ultrasound, and the application of innovative technologies such as laser interstitial thermal therapy and robotic assisted navigation. Her current focus lies in the management of brain metastasis and translation research in mechanobiology through projects such as MetaMech Master Protocol in collaboration with the IFOM. She is also deeply committed to training the next generation of neurosurgeons and to fostering multidisciplinary collaborations in the treatment of complex renal pathologies. We are extremely honored and grateful to her for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from Turkey, Professor Ihsan Solaroglu. Professor Solaroglu is a neurosurgeon and professor at the Koç University Department of Neurosurgery. His secondary appointment is adjunct professor of basic science research at the Loma Linda University School of Medicine, California. With a clinical interest in neurovascular surgery and neuro-oncology, he has co-authored well over 80 papers and has more than 3,000 citations. He has served as a member of the World Federation of Neurosurgical Societies Neuro-Oncology Committee and Neurovascular Disorders Committee. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Xu Ming for broadcasting this webinar on the WeChat channel. Dr. Ben Eng from Hong Kong is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Cecilia Casali.
Thank you. Good afternoon, ladies and gentlemen. It's my great pleasure to welcome you all to today's session of the ACNS webinar. Before we begin, allow me to share a few brief reflection on the topic we are about to explore, the intraoperative ultrasound in neuro-oncology. Over the past decades, intraoperative imaging has transformed the way we perform neurosurgical procedures. Among these tools, ultrasound has emerged and as an especially valuable modality, fast, real-time, repeatable, and significantly more cost-effective than intraoperative MRI. In our own hospital, we began using intraoperative ultrasound many years ago, initially with caution, then with growing confidence. Today is its indispensable part of our daily neurosurgical practice. From tumor localization to resection control, we rely on it as a reliable and efficient tool, one that not only improves surgical precision, but also enhances patient outcomes. The learning curve exists, of course, but the clinical and economic advantages are undeniable, especially in resource-constrained settings. It's therefore a real privilege to introduce today as distinguished speakers, Professor Ali Asghar Moyadi from India. Professor Moyadi is one of the leading voices in the field of neurosurgical oncology, with a particular focus on affordable and impactful technologies in neuro-oncology. Based at Tata Memorial Center in Mumbai, one of the most prominent cancer centers in Asia, Is it built a reputation for clinical excellence and academic leadership, especially in the use and advancement of intraoperative ultrasound techniques. His work has significantly contributed to making high quality neurosurgical care more accessible in low and middle income and countries, aligning perfectly with the goals of global neurosurgery. So please join me in welcoming Professor Alias Garmoyadi, who will speak to us today about intraoperative ultrasound in neuro-oncology, a low-cost, high-efficiency strategy for global neurosurgery practice. So welcome, Prof. Moyadi.
Thank you, Professor Cecilia. Thank you very much for that kind introduction and very generous one at that. Thank you very much. Thank you, Professor Raja, for having me on this webinar, which I am so excited to be part of. And thank you for having done this wonderful educational activity over so many years consistently. And of course, thank you for the ACNS and the entire education committee and President Professor Kato for organizing this very, very useful activity. So I would start off with my talk, but I'm very grateful for Professor Cecilia for having introduced this very, very relevant and very pertinent topic. And as she rightly pointed out that uh, as reflected in my own experience over the last 2.5 decades, I've seen how intraoperative ultrasound has evolved, how it has metamorphosed into a very, very useful, and I would probably go to the extent to say an indispensable part of the armamentarium of neurosurgeons, especially when we're dealing with oncology. But as I would like to point out, and I will show you in the rest of my talk, also to other specialties in neurosurgery. Um, a small disclosure is that since I'm a neuro-oncological surgeon, most of what I will talk about is based on my experience in neuro-oncology. And I hope that it also can be extrapolated, as I already said, to all other specialties in neurosurgery. Now, when we talk of neuro-oncology, essentially, it is important to build the rationale for why we are going to talk of intraoperative ultrasound and in general, why intraoperative imaging. So as neuro-oncology consists of tumors and the poster boy, or I would say the most common tumor that we usually see is intraaxial tumors and gliomas. And generally, when we deal with tumors like gliomas, there is a dual endpoint and an outcome that we are chasing. One is, of course, the oncological outcome in terms of survival, which is the long-term outcome. At the same time, we are also trying to resect this tumor and balance the neurological outcome, which is the short-term outcome that we are trying to balance. And often these dual outcomes are in conflict with each other. And that's why what we always try to do is to maintain this fine balance. Safe maximal resection is the dictum that we always try to follow. If we look back and reflect as how we are doing as neurosurgeons in achieving this balance, I think we realize that it's not always as we would expect. Even when we think intraoperatively that we have removed everything to the best possible extent that we could have, often we are proven wrong if we have a very objective way of assessing it, that is, use a postoperative MRI, which hopefully most of us do after tumor surgery. And surprisingly, or I would say rather unsurprisingly, we would find that in a lot of these cases, tumor residue which we thought should not be there is found. This is an inadvertent residue. And this points to the fact that there is often a discordance between what we set out to achieve and what we actually land up achieving. And there are many reasons why this happens, some of them within our control and some of them beyond our control. There could be problems in placing the craniotomy, in identifying the tumor, in delineating its extent, especially when it is imperceptibly merging into white matter, and many other reasons as I have enumerated over here. And as neurosurgeons, when we plan any neurosurgical procedure, we always try and aim to minimize these errors so that we can maximize the outcome. It starts with ideal case selection. in oncology, you would obviously decide whether this is a case suitable for radical resection or no, and then would go on to plan using a plethora of preoperative planning tools, including clinical neuropsychological evaluation, functional MRI, etc., etc. And then importantly, during surgery, you implement a right technique of resection, microsurgical technique, and finally, combined appropriately with the right adjunct, which will aid and minimize those inadvertent errors that I talked about. And talking about adjuncts, we have a whole gamut of them which help you improve your resection, either imaging wise or bioimaging, optical imaging techniques like fluorescence. And then you have to complement them with functional mapping and monitoring because that's equally important in striking the right balance. Now, ultrasound is part of this armamentarium. Now, when we have so many adjuncts and so many techniques and technology that we use in the operating theater, I think it is important as healthcare providers, as clinicians, as surgeons, to understand how useful these technologies are. So when you look at technologies, I think the first and the most important aspect to understand is how efficacious it is. What is the efficacy? Does it do what it is supposed to do? And this is evidence-based medicine. Usually in the context of drugs, it's done in the form of randomized trials. May not be possible in surgical technology research, but this is the proof of principle. And this is what you would say is the ideal performance of a particular technique, treatment, drug, or equipment. But more importantly is how it performs in the practical day-to-day setup. When you implement it into routine practice, how does it work? And this evidence is generated usually from a lot of large observational studies, from routine care practice, and often comparative effectiveness research between different treatments, different techniques. And this is the practical benefit of the treatment. But finally, most importantly, when it comes to implementing this on a large scale, is what we call efficiency. Is this something which can be used everywhere in all kinds of setups? Is it available? Is it convenient to use? Will most people adopt it? And how costly it's going to be, cost effectiveness. And all this provides what is called as value to that technique. So having an ideal technique which has no practical relevance and is low on value because it's either unreachable or too costly, probably may not be very useful. This is what we need to keep in mind, broad context, when we talk of intraoperative ultrasound. And technologies or equipment is just one component of all healthcare costs. You must remember that. And therefore, understanding, optimizing that is very, very important. Coming to ultrasound itself, if we go back in time in history and try and look at the development or the emergence of ultrasound. So ultrasound came into medical practice by import from research done in military and industrial technology. And it started being used as a tool for diagnosis. Now, this is just some images from very old publications where you have these rather large, cumbersome machines and these unwieldy probes, which gave some kind of images, which today we would call very poor resolution. But this was the status of ultrasound, and it was a revolution in those days. And interestingly, in the intraoperative setting, the ultrasound was used in a neurosurgical theater, probably as the first application of intraoperative imaging, as against its use in other intraoperative or surgical setups. However, as CT scans emerged in the late 70s and the MRI in the 80s, and neurosurgeons became more familiar and accustomed and comfortable with these multiplanar high-resolution images, the ultrasound started falling into kind of disuse. Only with the realization that image-guided surgery based on MR can be inaccurate, especially in intraaxial tumors because of this phenomenon of brain shift. And paralleled with that, improvements in ultrasound technology, which happened in the last decade of the last century and the early part of this century, there has been a resurgence in intraoperative ultrasound. And it has, I would go to the extent of saying that, taken the neurosurgical world by storm. Now we have ultrasound equipment and refined probes, which provide image resolution of the highest order, be it cranial, spinal, or even functional imaging like angiography. And this can rival the MRI and sometimes provide intraoperative information, which maybe even the MRI is unable to provide. And a very important component of its application in the intraoperative setting, though not the only one, but still a very important component, is its use as a resection control tool, which means, going back to the early part of my presentation, that to assess the residue and guide surgical decision-making intraoperatively, it is a very important application of the intraoperative ultrasound. And these are just some examples where the ultrasound is used as a serial resection control tool, be it in the form of 2D ultrasound or even multiplanar co-registered navigated ultrasound, which I'll briefly talk about in the course of my presentation. So it's not because I am saying that or a handful of people are saying that ultrasound is useful. Let's scientifically evaluate what evidence we have for the efficacy and the effectiveness. And then finally, we'll talk of efficiency and cost effectiveness of this technique. If it has to be used as a resection control tool, it has to be accurate in predicting residue intraoperatively, which means that you need to know with reasonable certainty that what the ultrasound is showing is going to be tumor. And there are many studies, but I would like to highlight this one, which is probably one of the best, and a very old study where the group led by Professor Unskard from Trondheim in Norway, who were pioneers in the application of intraoperative ultrasound, conducted a comparative evaluation of the efficacy or the accuracy of intraoperative ultrasound with navigation compared to navigation in predicting tumor residue for a range of intraaxial tumors, including metastasis and gliomas. And what they did was they had MRI imported into navigation. They pointed out to different regions within the tumor and outside the tumor, intraoperatively navigated, took biopsies, looked at the findings corresponding to the navigated T1, T2 weighted images, and also they had ultrasound incorporated into the navigation, and they looked at the same ultrasound features, whether it was showing tumor or no tumor, and compared it to the gold standard, which was the biopsy histology. And what they found was, interestingly, is that the concordance between the respective imaging finding and the histology, that means imaging shows tumor and histology shows tumor, is concordant, otherwise there's discordance. This concordance, as indicated by the black component, the dark component of these bars, was highest for the ultrasound across the range of tumors: gliomas, low-grade, high-grade, glioblastoma, metastasis. So this means that the ultrasound intraoperatively can accurately pick up the residue, at least as good as, maybe better than the navigated T1, T2 images. One obvious criticism here is that the comparator, that is T1, T2 weighted image on navigation, could have been erroneous because of brain shift, and therefore the accuracy was wrong. And that is possible. But here I'd like to highlight this other study, which looked at a similar scientific setup. But here they used intraoperative MR and they used intraoperative ultrasound, besides, of course, ALA, to do a similar comparative analysis. So there is no question of brain shift having affected the accuracy of either of these, because all were intraoperatively applied techniques. And what they showed was that a same result, that the ultrasound was as good, and in fact, in certain situations, better. So no technique is perfect, and I think all of us agree on that. With keeping this in mind, the ultrasound performed as well as the intraoperative MRI when it came to picking up tumor residue. And since then, numerous studies, and there is collective meta-analysis and systematic reviews which have verified that the diagnostic accuracy of intraoperative ultrasound is high, in the high 80s and 90s, which is very good in terms of diagnostic accuracy. And there are two of these which I have shown, but there are many other studies which show the same. So of kind of a first conclusion that we come to is that the intraoperative ultrasound is reliable and accurate in detecting residue intraoperatively. How does this accuracy translate into practical usefulness? We talked about efficacy, now we're talking of effectiveness. So we looked at, and this is our own publication and data, as to how the ultrasound, and this is just to show the diagnostic accuracy in our hands, but this is the flowchart that I would like you to focus on, is there we looked at how did the intraoperative ultrasound picking up a residue during intermediate stages of surgery influence our decision making and the course of surgery, which means that when we did the ultrasound intraoperatively at an intermediate stage, it showed us something, and then it changed the course of the surgery. And what we found was that in 40%, 42% to be exact, it changed the course of our surgery. And in most of these cases, 95% of these cases, it prompted us to resect further because it showed us residue, which we otherwise would have not, and we would have stopped surgery at that point of time. And this correlates very well with one of the other studies I showed you earlier, where postoperative MRI picks up inadvertent residue in a large number of cases where surgeons intraoperatively think they've got a complete resection. And put this together with that, it shows you that the ultrasound can plug this loophole to an extent. Particularly in non-enhancing gliomas, like low-grade gliomas or intermediate grade, where other intraoperative imaging techniques, for example, fluorescence, may not be that useful. And again, something I'd like to point out here in this paper that we published is that even in so-called unresectable low-grade tumors, which look diffuse, the ultrasound still could help us chase tumor intraoperatively and achieve a gross total resection in a third of the cases. Of course, balanced with functional mapping and monitoring to ensure functional outcomes are not compromised. And again, this is something we published many years ago. We looked at a small subset of glioblastomas where we calculated the volume of the contrast-enhancing tumor, and they all underwent ultrasound-guided surgeries. And post-operatively, we calculated the volume of the section cavity, and we found that the resection cavity, after adjusting for all other confounders, was much larger than the contrast-enhancing tumor, which means that the ultrasound helped us resect beyond contrast-enhancing tumors into the T2 flare component, which now we all acknowledge and know T2 flarectomy in glioblastomas is recommended, and that is prognostically beneficial to patients. And here again, the ultrasound as an intraoperative imaging tool can help you increase that resection and achieve that goal. So besides being efficacious, good diagnostic accuracy, it positively impacts the course of surgery and optimizes resection if applied correctly, of course. In terms of how does it compare with other imaging modalities, you have MRI, you have fluorescence imaging. I already showed you one or two papers, but I would like to here highlight that the extent of resection that is achievable, and this is a meta-analysis of ultrasound-guided surgery papers, showed that the GTR rate was in the range of 72 to 77% for low and high-grade tumors. Okay, so the comparative accuracy, unfortunately, head-to-head in randomized trials have not been tested, except for one small randomized trial, which I'm aware of, between MRI and ultrasound, which was not powered enough to assess the outcome. If you look at the collective body of literature for MRI, for ALA, for ultrasound, they're comparable. The ALA study, for example, the randomized study showed a gross total resection rate of 66%. But since then, ALA literature has emerged, which shows gross total resection rates in the range of 80–90% in high-grade gliomas. The ultrasound literature has high-grade and low-grade, and therefore in low grades, the extent of resection may not always be that high and depends on what you consider as GTR. And therefore, broadly speaking, the resection rates are comparable across the imaging modalities. So it performs well even when compared with other modalities. But what more does it offer? So as an ultrasound, which is an intraoperative tool, it's not just resection control that you're talking about. And there are many other small things intraoperatively that you look to try and optimize. You're trying to place the craniotomy, or in spinal surgery, you want to see the extent of your laminectomy. You want to see whether you need to modify it a little bit. So we did a small pilot study many years back to understand there's no scoring system. We just devised one, which is a simple yes, no about whether it was helpful at each stage during craniotomy for tumors. This is for cranial surgeries. And we gave scores in a series of patients about how the surgeon felt. And what we saw was that it was very, very useful. Percentages of utility being close to 100 in all stages of the surgery, except, of course, the craniotomy placement, because as we know, the ultrasound is not useful before the craniotomy is done, and their navigation would be probably more useful, or a good surgical anatomy knowledge. And it was not just individually that there was very high percentage utility, but collectively in each surgery, it was not just one step, but multiple steps which were found to be benefited by the use of the ultrasound. This is just a kind of a utility score that we had, which told us that the ultrasound is actually multifaceted. It helps you in identifying lesions, localizing, be it for biopsy, be it for tapping, be it for cyst evacuation, etc., or lesion delineation and extent of resection assessment, resection guidance, and very importantly, identifying normal anatomy and getting your bearings right intraoperatively. Not only that, but intraoperative ultrasound is more than just grayscale imaging, B mode imaging. You have fusion imaging with where you can fuse it with MR navigated. You have Doppler imaging, multiple techniques of doing it. You have elastosonography, you have contrast enhanced ultrasound. So it is actually truly a multifaceted technique. And I will just show you glimpses of what all it has to offer. Navigated ultrasound or fusion imaging basically utilizes the power of navigation with the real-time 2D ultrasound imaging capability. And what it does is that it lets you navigate with the ultrasound images in multiple planes if you require, thereby improving image orientation and a field of view, which is sometimes a problem with ultrasound, and allows you to spatially and temporally, serially during surgery, to compare images. Very importantly, it also helps you identify brain shift. And now there is technique emerging, and there is some commercial availability of this technology in some of the navigated ultrasounds for correction of brain shift. So this is an important and an exciting area of future development. So you have both 2D, 3D navigated ultrasound, which is useful for multiple functions. In our own experience, we've seen that the 2D ultrasound itself is the workhorse. It's useful in more cases. 3D navigated ultrasound has certain specific benefits, like I mentioned, and it is useful in certain situations, especially resection control in complex locations. And there is always a learning curve, and this learning curve is easily achieved if you have the right training and you apply it correctly during surgery. Besides navigated ultrasound, you have Doppler that I mentioned, standard spectral Doppler, which we all are used to doing. We do transcranial Dopplers or intraoperative Doppler. But what I find very useful during tumor surgery is the color Doppler, power Doppler application, and the angiography, real-time angiography that you can get, which is it's a cross-sectional angiography, unlike, say, when you use ICG or something in vascular cases where you can only see the superficial structures. This is an example of how a 3D reconstructed angiogram intraoperatively in insular glioma can help you, where it shows you the bifurcation of the MCA and sometimes even the lenticular striate vessels. Or it could be very useful in assessing the patency of vessels pre and post resection, for example, in this perisylvian glioblastoma, where you see the MCA vessels in the sylvian fissure and can reasonably assess the patency after the resection. Then you have elastography, which is basically a type, it's a different and a complementary way of using ultrasound. It doesn't give you images based on echo, but it gives you images constructed based on the perceived stiffness of the tissue, which is a tissue characteristic, whether it's hard or soft. And there are different ways of doing it, strain imaging, shear wave imaging, and we'll not go into that. But suffice it to say that it gives you a quality of tissue structure, which is a different characteristic than the echo characteristics that we get on standard 2D ultrasound. And it gives you additional information. More information during surgery is always useful. So whether the tissue is going to be harder or softer relative to the surrounding brain, for example, here. As an academic exercise, it also helps you understand different components of the tumor, correlating it with MR and then maybe even certain molecular and tissue characteristics. Again, a similar example of a multi-compartmental perisylvian glioblastoma, different components reflected well on the elastography also. And then we have contrast-enhanced ultrasound, which is something which is emerging. It is based on the property of air or gas bubbles to impart contrast characteristics when they are insolated. It uses basically sulfur hexafluoride particles, bubbles coated in nanoparticles, and is useful. And this is actually work emanating from a lot from Italy, where its usefulness in tissue characterization, in microperfusion visualization helps and provides adjunctive information in surgery. So the ultrasound is not only efficacious, effective, but it's also multifaceted. And because of this, it has found applications, as I said in the beginning, not just in oncology, but across the spectrum of neurosurgical specialties, including vascular surgery, minimally invasive surgery, skull-based, spinal, pediatric surgery. Just to give you examples, minimally invasive surgery is very well suited to ultrasound, especially with finer, smaller probes now available, which allow you to do targeted imaging, and that can be used in conjunction with endoscopic surgery, endonasal, ventriculoscopy, spinal endoscopy, everything. In spinal tumors particularly, and I like to spend a couple of minutes on this, it's also very useful, something which is not discussed very often because the tendency is to focus on cranial, but it can be very useful in spinal tumors. You have to use more high resolution linear probes with smaller footprints, and those are now available. What it helps you is to understand, for example, in extradural pathology, the extent of the decompression that you may need to do and assess whether there has been adequate decompression of the spinal canal. In certain intradural tumors like this, it allows you intraoperatively to identify the tumor extent, to understand the pathology that you're dealing with, and to pick up multiple lesions, in this case, drop mets from an ependymoma, which otherwise would be missed. In certain intradural pathologies, which are sometimes dubious in terms of their MR appearances, the ultrasound can be very helpful. Like, for example, this complex dermoid, where the ultrasound showed the intramedullary as well as the exophytic intradural component and allowed us to resect it with a resection control scan so that you don't miss anything. And then intramedullary tumors, where ultrasound is very useful, helps you identify the rostral and caudal extent, the thinnest part where you may need to do a myelotomy, cysts or syrinx if you have one. However, here I would say that the intraoperative neuromonitoring remains the cornerstone, and therefore the ultrasound is an added adjunct and a guide. But the intraoperative monitoring is most crucial in achieving your outcome of safe resection. So the ultrasound becomes a very, very versatile tool, multi-purpose, different range of surgeries, different applications during each surgery. And it gels very well with the surgical workflow. No matter what kind of OR you have, what kind of surgeries you do, it mixes very well and adapts very easily, does not alter or disturb the surgical workflow. And this is very, very important because it makes it convenient. It makes it easily integratable into most neurosurgical operating theaters. And it's something which is very ergonomic, does not disturb too much of your operating setup. And this is very important. It's also very easy to use. Performing a sweep during surgery to get a full scan, understanding the tumor. Of course, a little bit of knowledge, a little bit of training is essential, as in most neurosurgical procedures, but it's something which can be easily done. And I think very important is that this all is achievable or is obtained with a fraction of a cost of, say, the intraoperative MRI, provided you are able to achieve similar outcomes with the two technologies. The cost difference is enormous. And this is where the cost effectiveness of the intraoperative ultrasound emerges as a very, very, very powerful and a useful advantage. And mind you, it does not mean that something which is cheaper is likely to be inferior. It just means that you have an alternative maybe there are certain nuances in its use which need to be understood, which need to be optimized before you can extract its maximum potential. But if used ideally in an optimal setting, you can achieve the outcomes of the comparator. And with this powerful cost effectiveness, which makes it very attractive and more accessible, it can kind of break barriers. We have neurosurgical setups in our country, in India, for example, a range of setups from very high volume metro centers in big cities to even small setups in smaller second and third tier cities and towns. And this is the same situation across the world. And you would want people doing this kind of surgeries, not just in a few of the centers, but all over. And similarly, for every place in the world where you would want this to be implemented. And therefore, this kind of a surgeon-friendly tool fits the bill very well. And it's no wonder then that in the last decade or so, if you go back to even literature which is published, academic literature, you see a shift from intraoperative MR towards intraoperative ultrasound, with a lot more papers emanating which talk about the benefit of ultrasound, which means that there are a lot more people who are adopting it, a lot more people who are evaluating it, and hopefully a lot more people who are disseminating this. Finally, I'd like to say and end with saying this is that, I've been highlighting and I've been reiterating this during my talk is that provided the ultrasound is used well, it will achieve the benefit that we are talking about. And therefore, important and very important for neurosurgeons is to understand how it is to be used and applied. Because if you do not acquire a good ultrasound scan, then you obviously cannot do anything more beyond that. Two core competencies that ultrasound that neurosurgeons need to acquire is to perform and acquire a good scan, and secondly, understand and interpret that scan. And these two are related to each other, which is where you need some kind of training to bridge the gap, which is what is now available and which is something which all neurosurgeons should probably do. A lot of the training can happen by yourself as long as you know the basic principles, which include acquiring a good scan, right positioning of the patient, using the right probe, understanding the different orthogonic planes that you need to insonate it, understand ultrasound semiology or image characteristics, understand what tumor resection cavities look like, what a residue should be, what will be artifacts, and how to avoid and minimize them. And this competency in image acquisition and interpretation is the key to doing good ultrasound guided surgery. And if that is possibly done, then you have the ideal situation where you're well trained to perform it. It's also very practical and it brings value, adds a lot of value to your neurosurgical setup. With that, I'd like to end my talk, and I'm happy to take questions and comments from the experts and discuss this further. Thank you very much.
Thank you very much, Professor Moyedi, for this insightful and highly practical presentation. Just a question, just to understand: do you use the contrast enhanced ultrasound routinely, or in some cases?
No, actually, we don't use them at all in India
Mm.
because of the licensing issues. We've used
Oh,
only in a couple of cases as a part of some study, or where we've had special permission to use it for demonstration. But
okay.
we otherwise don't use it because its application. I know in Italy it is approved now for use cranially, but here
For the adult only for
for
the
that,
adult, not the
yeah,
pediatric surgery. That's why we are using it for off label and try to understand. I
correct,
know it's just to understand. Okay.
yeah.
So, and what strategies or training methods would you recommend to improve usability and confidence for the young neurosurgeons? I think that they have to use it every day, every time, in every moment to understand. Yeah, I think
Absolutely.
on my experience.
Absolutely. You're right
Yeah,
on that. The more you use it, the better you get.
yeah,
And you start using it in every surgery where you may not really require it, but you get to understand the
yeah.
basics, how to set it up, how to optimize the image, what is a high gain, low gain, how to focus. because then when you really need it in those surgeries, it is kind of, it just works seamlessly and without causing any problems. I would say that for residents and young trainees, they should try and use it with supervision initially, so that the basics of most people get intimidated by the machine and the controls, and they become kind of disillusioned when they do not get a good image. And that's often because they don't know how to use it or optimize the settings. I think once that small problem is solved, then it becomes a self-discovery exercise every time you do a new case, because you discover new things and you discover new advantages and utility of the system.
Yeah. And I think could be very useful also for emergency neurosurgery, like intraparenchymal hematoma, or to rely the truly,
Absolutely. Absolutely.
and also for spinal surgery, when you just open the laminas, are trying to understand if you are in the right position. You can
Correct.
perform ultrasound,
Absolutely.
and to understand if you have to just open a little more, or could be really useful. But they have to remember they have to use it every day. The first
Right.
days you will not understand anything, maybe,
True.
but
True.
every day you will understand much more. Yeah,
Correct.
yeah.
Thank you, Cecilia. We have two raised arms. Professor Solaroglu, we'll start with you.
Thank you very much, Professor Mayadi. It was really nice talk. Just, I want to ask that, especially the tumors located in the subcortical area, when you remove the part of the tumor or cystic component of the tumor, then the cortical surface is, dropped.
Collapses.
That's why it is sometimes difficult to use the probe during the resection, and especially the tumor left at the subcortical area could be difficult to differentiate with the normal tissue. Are you filling the cavity with the water or something else to check once more whether the subcortical unseen area is totally resected or not? Is there any trick from you?
Yeah, no, I think it's a very valid point. And in fact, these are the reasons why younger residents, they find it challenging. So you're right, when you have a large cystic lesion or a large tumor collapses, and then the cavity folds on itself and you get a lot of artifacts. So yes, instilling saline is very important. What we also emphasize when we do these training courses is that before you start your resection, try and imagine what the cavity will be at the end and position the head such that you get a vertical cavity which you can fill with a horizontal saline level, because otherwise it will be difficult to insonate. And then there are certain techniques which we use. Either you use a very fine probe, you have these linear, hockey stick kind of probes. You can put it into the cavity and apply it on the edge all around, which shows you a very high resolution image. Or you insonate the cavity, the undersurface of the cavity from the adjacent brain. So that means you eliminate a lot of the causes of the artifacts which happen because of the cavity. So this is certain techniques which need to be understood and which we routinely do when we conduct these training courses. There are some artifacts which happen because of water filled in the cavity, enhancement artifact. And there are again these ways and tips and tricks of avoiding them. There's also some special acoustic fluid which is now under testing in clinical trials, which actually has impedance similar to brain and eliminates these artifacts. And if that becomes approved and widely available, it could potentially be a game changer. So there is a lot of exciting things happening, and all of it is aimed at trying to optimize these image characteristics actually and avoid artifacts, which you rightly pointed out.
Thank you very much. What we are doing, actually trying, putting the cotton to the field, filling with, because it has specific echo in ultrasound. And you can differentiate the cotton, the tumor, and the normal brain tissue. It could be a solution, but still we are trying it.
Yeah.
Thank you very much.
Thank you.
Thank you very much. Yes, Ben?
Yes, and Hello, Ms. Span from Hong Kong, and thank you so much for your great presentation. And I do share the same opinion with you that the intraoperative ultrasound is quite useful, especially with that navigated ultrasound, and we could combine it with the brain lab and also to try to correct the shift, the brain shift. I would like to ask about your opinion or experience in using the elastography. You know, there's some raising concern or some school of thought that the elastography can distinguish on the elastography based on the ultrasound can distinguish between the normal brain and also the tumor. So what is your opinion to that?
Yeah, no, I'm aware of that. And actually, I must say that our use of elastography is still very exploratory. We are trying to understand these exact questions which a lot of people have proposed. So, as I said, the elastography is a complementary way of interrogating the tissue against echo characteristic. This is the strain characteristic. So, even in elastography, there are two techniques, strain imaging and shear wave elastography. So certain machines allow you to do shear wave elastography, which is more objective. What we do is very often the strain imaging, which is relative. It compares the tumor in the patient to the surrounding brain. But across patients, you can't compare because it's not an objective assessment. Coming to your question, what it does is that it tells you subtle differences in tissue characteristics, but whether those differences are equal to tumor or no tumor is something which is still to be proven. So it could be edema, which appears a little different, infiltrating tumor, which appears a little more stiffer than edema, or vice versa. These are all questions which still need to be answered. So it shows you differences. It's like, bioinformatics. It throws up a lot of data, a lot of information. But what you make of this information is, I guess, all of us who use the ultrasound or elastography need to answer going ahead. So yes, it has potential use, but I think we still have a lot of work to do before we can say that, or we can put, kind of guidelines as to what it means.
I see. Thank you so much.
Thank you so much. So now we have come to the end of this session. We can take the final remarks from Cecilia before we move on.
So thank you all. This has been a very interesting topic. Thank you to Professor Moyari and the other speaker, and see you on the next webinar.
Well, thank you very much. It was indeed very, very useful talk from Professor Aliaskar
Yeah.
Moyadi, and we understand that the future is very bright for ultrasound, and we hope that this is integrated more into our current practice, and we can then move on further, as Professor Moyadi mentioned in his lecture about elastometry and the other novel buffering solutions and all. So we'll look forward to it, and we hope that we can live up to this, Prof. Moyadi. Thank you very much for teaching us. I would like to mention that this has been broadcasted on WeChat, YouTube, and Zoom, thanks to Professor Shubin. And as of now, we have around 924 people who have logged in on the WeChat channel through across all the different parts of the world. Thank you very much. So I'll hand this podium over to our second chair, Prof. Ehsan Solaroglu, who will say a short introduction and invite Prof. Shuming for his lecture.
Thank you very much again for the first speaker, and now we are moving the second session. Good afternoon from Istanbul. Today is sunny day and nice day for a webinar. Our next speaker will be Shuming from Shanghai at Fudan University, and he will be sharing his experience with hypoglossal schwannomas, which is a hard topic actually for skull-based surgeons. If we give why the topic is important for us, because having an experience in this pathologies is quite difficult, because those tumors constitute about only 1% of all intracranial schwannomas. Because of its rarity, generally when you look at the literature, you can find out 2 or 3 cases per paper. and the largest series has like 10 or 15 patients in 30 years or 20 years. In those tumors, commonly this initial symptoms is headache, and many patients has late diagnosis because hypoglossal nerve palsy usually appears as a signs rather than symptoms, and unilateral tongue atrophy or paralysis usually do not disturb the speech or swallowing or chewing. So that's why, because of these minimal disabilities, patients diagnosed very late. It is important for us, and also because of this, more than 50% of tumors diagnosed at the late stage when the tumors were big. So the surgical resection of hypoglossal schwannoma is not easy, especially during the last 20 years. We had important contemporary techniques to remove. Professor Minshu will probably talk to us. And now the stage is for Professor Shu Min. Thank you. Please.
Okay, thank you, Professor Raja. Thank you, Professor Kato and Professor Chiping's invitation. Today, my topic is microsurgical management of hypoglossal schwannomas. I'm Chiming from Huashan Hospital. Later, as a hospital, we had 4 campuses in Shanghai, and the Western campus is mainly for neurosurgery. Our neurosurgical department is a national center for neurological disorders in China. And this is our team of skull-based surgery. And there was no conflict of interest associated with this talk. These are the contents of my lectures. As you know, schwannomas are usually arise from sensory nerves, such as our vestibular schwannomas, trigeminal schwannomas. But schwannomas are rarely arise from purely motor nerves, such as our hypoglossal nerve. So the hypoglossal schwannomas are rare. They only account for about 1 to 7% of non-vestibular head and neck schwannomas. The hypoglossal schwannomas can arise anywhere along the course of the hypoglossal nerve. When the tumor arises from the nerve in the mouth space or submandibular region, this tumor are always treated by oral and maxillofacial surgery. Our neurosurgeons are usually treated the lesion invaded intradural, intracannular, and the high cervical region. Microsurgical management of hypoglossal schwannomas can be challenged due to the necessity of a complex skull-based approach and proximity to the additional lower cranial nerves. So from this picture, we say the hypoglossal schwannomas are very close to vital, vascular, and lower cranial nerves. So if you want to remove the hypoglossal schwannomas, you need to well understand the microsurgical anatomy. For the distal segment of the hypoglossal nerve, we can see the hypoglossal nucleus bulged into the floor of the fourth ventricle. This area is called hypoglossal trigon, and the intramedullary course of the nerve is like the second. They exit the brainstem in this area, the root exit zone, which is located medial to the olivary and lateral to the pyramid. So it exits from the pre-olivary sulcus. And then we see the distal segment. There are 3 to 6 root bundle, and they merge into 2 to 3 trunk, and then enters the dura. The system segment is located superior to the vertebral artery and ventral to the accessory nerve. And in the hypoglossal canal, there was the oblique trajectory of the hypoglossal nerve, which is the occipital condylar. You can see the nerve from the posterior to anterior, from medial to lateral. In this picture, we can see in the medial inner orifice, the hypoglossal nerve is located anteriorly. So when you perform the transcondylar approach, you draw the condylar, you really can injure the hypoglossal nerve. But in the outer orifice, the hypoglossal nerve is very close to the dorsal surface, so more care should be taken in this area. And we can see the hypoglossal nerve passes the hypoglossal canal, and this is a jugular tubercle, which is located between the jugular foramen and the hypoglossal canal. So if you want to open the hypoglossal canal to show the tumor, you can do more drilling in the superior and posterior part. You need to do more drilling to the direction of jugular tubercle and keep the intact of the joint to keep the cranial vertebral stability. Within the hypoglossal canal, we can see the hypoglossal nerve is surrounded by the venous complex, which is named as the anterior condylar vein. And during the operation, the bleeding from the vein can be controlled with the gel foam. Soon after leaving the hypoglossal canal, the hypoglossal nerve enters the carotid sheath that runs just behind the vagus nerve. We can see this is the IJV and the accessory nerve. The hypoglossal nerve located anterior to these structures. And in rotor collection, we can see this is the transverse process of C1, and this is the accessory nerve, and this is the IJV. We need to cut the occipital artery and then reflect the internal jugular vein and the ilnaris nerve to show the hypoglossal nerve and the vagus nerve. And the hypoglossal nerve cross the lateral surface of the ECA and then across anteriorly to the submandibular region. And from this video, you can see the glossopharyngeal nerve cross the lateral surface of the ICA in the high region, and the hypoglossal nerve cross the vessel inferiorly, and the hypoglossal nerve and the vagus nerve cross together in this region. So when the tumor invaded this region, it is more easy to injure the vagus nerve. If you injure the hypoglossal nerve and the vagus nerve at the same time, the patient will have a big problem to swallow because the vocal cord paralysis. And so you need to try to preserve the vagus nerve in this region during the hypoglossal schwannoma removal. And the symptoms and the signs, we can say about 60%, 64% of patients are female, and 36% of patients are male. The mean age was 44 years old. And we can say about 80% of patients had a hypoglossal nerve palsy, but only 38% of patients' chief complaint is tongue deviation, speech disturbance, because the tumor grows slowly. So some patients will tolerate the hypoglossal nerve palsy. The images We can see this is and the right side is normal hypoglossal canal. This is the jugular foramen. Between these two structures are jugular tubercle. And we can see the left side, the tumor enlarged the hypoglossal canal and invaded the jugular tubercle and the jugular foramen. So we can see the margin is sharp because the slow-growing tumor compressed the bone. This is a typical sign of schwannoma. And then the microsurgical approaches. Professor Fukushima classified the hypoglossal schwannomas into 4 types. Type A is intradural type. Type B is dumbbell-shaped type. And type C is extracranial scar base. And type D is peripheral. They don't have patient with type D. And for type A, he used lazy S incision. He named it as dorsolateral extreme lateral infrajugular transcondylar transtubercular exposure elite approach. They use this approach to remove the intradural tumor. For the tumor with type B and type C, they use a C-shaped incision. She named it as a anterolateral elite approach. We can see he do more mastoidectomy to open the hypoglossal canal and expose the tumor in the high cervical region. And in the past 5 years, our team had 11 cases of hypoglossal schwannomas. We classified them into 4 types. For type 1 is the intradural type. We only had 1 case. For type B is intradural and intracannular type. We had 2 cases. The type 3 is intracannular and cervical type. We had 1 case. And type 4 is intradural, intracannular, and cervical type. We had 7 cases, which is most common. And our approaches for type A, type 1, we use the L-shaped incision to remove the tumor. And for type B, or type 2, we use a U-shaped incision to remove both intradural and intracannular tumor. And for type C, we use type 3, we use the C-shaped incision to remove the intracannular and high cervical region. And for type 4, we use U-shaped incision with the anterior limb of the incision more inferiorly. Our typical case, and this is a case 1. It's a type 1. It's a 64-year-old female. She accidentally found the tumor for 1 month. We can see the tumor located here, intradural. We use a L-shaped incision for this patient. We do some condylar drilling and make this part flat to expose the tumor. During the operation, found the tumor arised from the cysternal segment of the hypoglossal nerve. The tumor's arachnoid plane between the tumor and brainstem not very clear. So we only protect 1 trunk of the hypoglossal nerve. But in the vagus nerve located superior to the tumor, it was preserved well, which was identified by the vagus nerve monitoring. And after the operation, the patient came through well and no need for tubal feeding, and the tumor was totally removed. For type B, the second case, this is a 69-year-old male suffered from dizziness and dysphagia and weakness of right limbs for 3 months. We can see the tongue atrophy hemiatrophy. We can see this is a big tumor compressed the brainstem severely, and the jugular bulb was compressed, and the sigmoid sinus cannot be shown well in the MRV. And for this case, we use U-shaped incision. We see the video. We don't need too much mastoidectomy. We just remove the tip of mastoid and then do the mastoidectomy to expose the jugular bulb, suboccipital craniotomy, and remove the bone flap and the posterior condylar vein. We then drill the hypoglossal canal, jugular tubercle drilling, open the outer orifice of the hypoglossal canal, remove the open rectus capitis lateralis, and then we remove the posterior arch of the C1. And then we firstly open the dura in the hypoglossal canal. We firstly remove the intracranial part of the tumor. This part of tumor, blood supply is abundant. We use the CUSA to control the bleeding. We found the distal part of the nerve, and then we cut the nerve and control the bleeding from the nerve root. And the venous bleeding in the surrounding the tumor was controlled with gel foam. And they use CUSA to remove the tumor to the inner orifice. And then we move to the intradural part. Arachnoid plane dissection. We open the inner orifice and mobilize the accessory nerve posteriorly and debulk the tumor. The blood supply decreased obviously. We use the CUSA to debulk the tumor. This is a vertebral artery, and we found the nerve trunk. There are two to three trunk of the hypoglossal nerve. We coagulated it and cut it. In this type, the arachnoid plane between the tumor and the brainstem is clear. It's like the vestibular schwannoma goes from the hypoglossal canal to the intradural. So the arachnoid plane is clear in this type. And we totally remove the tumor, or small vessels, and the vagus nerve, the accessory nerve are preserved well. And we remove the residue tumor in the canal and totally remove the tumor. And then we use abdominal fat to close the dural defect. And then we use natural ligament to repair the dura in a watertight fashion. And we replace the bone flap. And after the operation, the patient recovered well, and there was no problem for swallow. And the patient had been followed up in 2 years. There was no recurrence. And case 3 is a patient with type 3 hypoglossal schwannoma. And this 50-year-old female, she was accidentally found the tumor for 1 year. During the 1 year follow-up, the tumor enlarged. So we performed the tumor resection. We used a C-shaped incision for this patient. We see the video. This is the accessory nerve. On the anterior to the accessory nerve, opened the carotid sheath and mobilized the tumor out. This is the distal part of the hypoglossal nerve. And we can see this is the vagus nerve located anterior to the tumor. So, and mobilize the tumor outside the hypoglossal canal. venous bleeding controlled with gel foam. And this is the proximal part of the nerve. We cut the nerve and explore the cavity, totally remove the tumor. And we use the abdominal fat to close the cavity. This is the follow-up MRI shows the tumor was totally removed. The patient comes through well. And the first case is the patient with type 4 hypoglossal schwannomas. The patient is a 51-year-old female, suffered from dizziness for 1 month, unsteady walking for half a month. We can see the tumor located intradural, intracannular, and then to the high cervical region. And we use the U-shaped incision with the anterior limb of the incision more inferiorly. We see the video. We open the tumor capsule. We firstly remove the tumor inside the hypoglossal canal. We can see the hypoglossal nerve, but we cannot preserve it. And we firstly debulk the tumor with CUSA and the nerve, and we cut the tumor at the outer orifice and remove the tumor to the inner orifice. After the intracannular part of the tumor totally removed, then we move to the high cervical region. It's the accessory nerve, and we open the carotid sheath under the accessory nerve. We created a window for the tumor resection. You see, we open the capsule, the subcapsule dissection. Use CUSA to debulk the tumor. Then we pull the tumor down, and we can see the tumor's blood supply is very abundant. And the superior part was totally removed. And then to the inferior part of the tumor, there are several roots, nerve roots, was found and cut. One by one, there are several nerve roots was cut. And this part of this is the ECA, and we cut the nerve root and totally remove this part of the tumor. And we don't use too much bipolar in this region because of the vagus nerve. And then we sutured the carotid sheath, then move to the subdura. The dura, in this part, the arachnoid plane is not also clear. This is the vertebral artery. The tumor is cystic. We debulk the tumor and then perform the arachnoid dissection. And we can find the trunk of the nerve and dissect the tumor away from the other lower cranial nerves. We coagulated the nerve and cut the nerve and totally remove the tumor intradura. And then we use the intraoperative monitoring to identify the vagus nerve and the accessory nerve were preserved well. And we use abdominal fat to close the dura defect. And the patient recovered well, no need for tubal feeding. And the fifth case is also a type 4 hypoglossal schwannoma. This patient found a neck mass for 1 month, and he had a right hypoglossal nerve palsy. We can see both the intracranial part of the tumor and the extracranial part of the tumor are very large. For this kind of patient, we use 2 stages surgery. For the first stage, we removed the intradural part of the tumor. We use the L-shaped incision to remove the intracranial part of the tumor. And 3 months later, we performed the linear incision to remove the tumor inside the hypoglossal canal and the high cervical region. And we can see the tumor was totally removed. But the patient, the extracorneal part of the tumor, blood supply is very abundant. So the patient need nasogastric tube feeding for 3 weeks. And the sixth case is also type 4 case. This is a 46-year-old female. She suffered from tongue deviation for 3 years. And 1.5 years ago, she underwent the left hypoglossal schwannoma resection in a local hospital. They used a midline suboccipital craniotomy to remove the intradural part of the tumor. But the intracannular and high cervical region part of the tumor was not removed. And after 1.5 year follow-up, we can see there was some cystic change of the intracannular part and high cervical region. So we can see they use a midline suboccipital craniotomy. They can only remove the tumor intradural. And because the cystic change tumor is not very well for gamma knife therapy or cyberknife therapy, so we perform the second operation. We use C-shaped incision. We see the video. We see the great auricular nerve. We reflect the suboccipital muscle posteriorly, ligate the occipital artery, and we don't need too much mastoidectomy. We just remove the tip of mastoid tip and reflect the posterior belly of the digastric muscle anteriorly and inferiorly. And this is a transverse process of C1 and expose the vertebral artery in this region and reflect the oblique superior muscle posteriorly and remove the rectus capitis lateralis to expose the IJV and open the joint to show the occipital condyle, and then we do the drilling. And this is the jugular process. We expose the inferior margin of the jugular bulbar and open the hypoglossal canal modularly to the jugular tubercle, and opening the outer orifice of the hypoglossal canal. This is outer orifice of the canal. And then we remove the this carotid sheath. It's the IJV. This is the accessory nerve. We open the carotid sheath anterior to the accessory nerve and open the capsule. We can see the yellow tumor. We create the window for tumor resection and debulk the tumor and then mobilize the tumor outside, then found the distal part of the hypoglossal nerve, and then we cut it. And mobilize the tumor from lateral to medial direction, and then remove the tumor piece by piece. You can see the cystic change. You can do more drilling to expose the tumor. But the joint was protected intact. And then we use CUSA to resect the tumor to the scar of the first operation. To totally remove the tumor, we need to remove the scar. We open the dura and remove the scar. And we can see the vertebral artery and the proximal part of the hypoglossal nerve. And we use abdominal fat to close the dura defect and fixed with fibrin glue. And there's use the abdominal fat to close the hypoglossal canal and suture the carotid sheath and replace the muscle and the mastoid tip and the posterior belly of the digastric nerve muscle was fixed. And the final issue is the reconstruction of hypoglossal nerve. Professor Fukushima used the sural nerve as an interposition graft. You can see he used the sural nerve to reconstruct the hypoglossal nerve. He treated this graft in four patients, and 3 patients had the functional recovery of the tongue after the operation. And as you know, to harvest the sural nerve, always you need a long incision, or you can use a small incision, but you need a special endoscopic technique to harvest the sural nerve. So we try to find a graft donor in our incision. The greater auricular nerve is not long enough, so we use the lesser occipital nerve as the donor nerve. And this is a young lady, 31-year-old female, accident found the tumor for 1 month. We can see it's a type 2 hypoglossal schwannoma intradural and intracranial type. And we use the U-shaped incision. In the incision, we harvest the lesser occipital nerve. We can harvest the nerve about 6 to 7 centimeters. It's long enough for the reconstruction. And we see the video. We firstly find the distal part of the hypoglossal nerve, use the intraoperative monitoring, and the debulked the tumor, the subcapsule dissection. The vagus nerve was preserved well, and we removed the tumor inside the hypoglossal canal. Venous bleeding is controlled with gel foam. We resect to the inner orifice. And then we move to the intradural resection. This is a vertebral artery. We cut the tumor in the inner orifice, debulked the tumor, and then pulled the tumor outside to the surface of accessory nerve. We cut the tumor, and then we sutured the lesser occipital nerve to the proximal part of the hypoglossal nerve. And then the lesser occipital nerve passed through the hypoglossal canal and then sutured to the distal part of the hypoglossal nerve. We need 2 to 3 sutures to fix the nerve. And we can see this is the final view after the hypoglossal nerve reconstruction. And the patient had been followed up about half a year. And after the operation, the patient had some disorder of speech disturbance. But at a 3 months follow-up, the speech problem has improved. There was some functional improvement of his tongue. And the outcome, we totally had 11 cases of hypoglossal schwannomas. And 1 case had the hypoglossal nerve grafting and no radiographic evidence of residual tumor in our patients, no recurrence, no days. And a hypoglossal nerve palsy in 10 cases, and vagus nerve palsy in 3 cases, accessory nerve palsy in 1 case. And the conclusion, and the surgical management of hypoglossal schwannomas requires different skull-based approach, transcondylar and paracondylar approach based on the extent of tumor involvement. The intercapsule resection technique contributes to the protection of the surrounding vital neurovascular structures. And nerve grafting can achieve functional recovery following microsurgery for hypoglossal schwannomas. This is totally my speech. Thank you very much.
Thank you very much, Professor Ming. It was wonderful presentation, and you show us the 11 cases that you already operated on, and this is a huge experience when you look at the literature. Congratulations for that. Thank you for sharing us with your experience. Is there any questions from the? Okay, Ben, we can start with you.
Yes, and thank you so much, Professor Xun, and very wonderful case series, and I really appreciate that your experience in tackling these rare tumors. And I would like to ask about in your experience. So, is C1 laminectomy and also mobilization of the vertebral artery necessary in every cases? Or how would you define when you need to do that?
So there is no need for the mobilized vertebral artery. We just only drill the occipital to open the hypoglossal canal to remove the intracanal part of the tumor. For high cervical region, there is also no need for mobilize of the vertebral artery. So we don't mobilize the vertebral artery during for our patients.
How about the C1 laminectomy? Do you need to
C1 laminectomy is useful for the intradural part of the tumor resection.
So if there is
yes, if there is an intradural part of the tumor, you need a C1 laminectomy.
I see. Thank you so much.
Thank you.
Thank you.
I have a question. Actually, when I look at the literature, gaining experience in this pathologies is quite difficult. And again, when we look at the literature, gamma knife surgery could be a safe option and effective option for these tumors. Do you have any suggestions or comments or experience with the gamma knife surgery in terms of efficacy? Do you have any?
Yes, in China, many we can see the 6 patients you see. Many neurosurgeons treated as hypoglossal schwannomas. They just remove the intradural part of the tumor, and for the intracannular and high cervical region tumor, they always treated with gamma knife or cyber therapy. But not every case can control the well, especially the tumor with cystic change. It's poor control with gamma knife or cyber therapy. So for this kind of patient, we also perform the second operation to remove the intracannular and high cervical region tumor. Thank you.
Thank you. We have a special guest here, Professor Luis Borba, the President-elect of the WFNS. It's a great honor to have you today, Prof. Borba.
Hello.
Hi, Luis. Welcome to our session.
Yeah, hello. How are you? Good morning.
Good morning.
I think good afternoon, good night. I don't know what time is there. Here is morning. I really appreciate. I was looking yeah, it's not so common tumor.
Yes.
I remember here I have 3 cases.
Yeah.
One was totally in the neck. Other one was more intradural. And the second one was a dumb shell. See, different the jugular foramen schwannoma that you have relation with the nerve. The hypoglossal schwannoma anatomically is the surgery is easier than the other one. and
Yes.
also the possibility to have some deficit. Sometimes it's difficult to understand the anatomy, but if you know this anatomy very well, you can remove the tumor with very, very low morbidity. And the morbidity is this 12 nerve. I saw in your series have one case that didn't have hypoglossal nerve palsy. Maybe I missed this case. In 11 cases, yeah. What was the reason? Was peripheral? You could preserve the nerve, or was not tumor from the 12?
The tumor arises from a trunk of the hypoglossal nerve. The other trunk of the nerve was preserved well, so the patient don't have the hypoglossal palsy after operation. This is an intradural type. Intradural type.
Okay.
The first case. Yeah, the first case.
Yeah. I lost this part. I was not online that time. And the only thing that I saw in this area here is very difficult to close the dura. See, watertight. No matter you do graft, you put everything. One good thing to avoid CSF leak is to put a lot of fat. You put fat, and rotate the muscle like a package. You see?
Yes.
I think is a good idea.
Yes, and I agree with you.
The third point, you have one nerve that is in the field. That is the greater auricular nerve. Is to extend the incision a little bit down here, around 5 to 7 centimeters. You have the greater auricular nerve. You can use this without necessity to go to the sural nerve or to find. The lesser occipital nerve, for me, I think for you, you have more skill. It's difficult to find sometimes the lesser occipital nerve because it's very small. And the greater auricular nerve is easier to find. You know what's the trick to find the greater auricular nerve? To find the external jugular vein. When you find the external jugular vein, just beside the vein is the nerve, the great auricular nerve. You can take sometimes 5, 6 centimeters, how much you need. In the case that I didn't do the reconstruction. Maybe next time I should try. But if the patient has deficits already, it's difficult to recover if the deficit is already severe. Maybe if the patient has no deficit and you cut in surgery and you reconstruct, maybe you can get some recovery. But very nice presentation, very elegant, as always. As the people does from China, from Funda University. Congratulations.
Thank you, Professor. Thank you, Professor. Thank you. Thank you very much.
Thank you very much, Ming. Any other questions?
Yes, I would like to ask one question to Prof. What sort of neuro monitoring do you use, if at all? Do you use any intraoperative neuro monitoring in these patients?
We need to monitor the vagus nerve and the accessory nerve and the hypoglossal nerve.
So, do you use then with an endotracheal tube? The electrode is within the endotracheal tube, or where do you?
We just use the needle incision in the neck for the vagus nerve monitoring.
Okay.
We don't use the tuber. Yes.
Okay. Thank you very much. Yes,
question.
Yes, please.
There is another question from.
May I have a question?
Yes, please, Duong. Go on.
Okay. Thank you for your amazing presentation. I have one question for Professor Min Su. Do you perform the surgery by only microscope, or you need the assistance of an endoscope or not? Thank you.
We perform the tumor resection. We use a microscope. I think the endoscope can be used when you remove the intracannular part of the tumor. You can use it to make sure the tumor was totally removed. You can use the endoscope to check the canal. It's useful, I think. but I don't use it.
Thank you. Thank you very much.
Thank you. Thank you.
Prof.
Thank you.
Cecilia, any questions from you, Prof. Cecilia?
Now, do you often use use the semi-sitting position or only the park bench or the lateral position?
No. We use the supine position for
Okay.
the supine position or lateral position.
Okay.
Okay.
Thank you.
Thank you. Thank you.
Thank you very much. We can go back to our chair, and here is
Thank you very much. Thank you, Shumin. It was really nice presentation and a huge experience in this region and in these pathologies. As I told you at the beginning of my talk, gaining experience in this region is not easy, having 10 or more patients. Thank you. You honestly share your experience with us. And especially the young neurosurgeons will absolutely benefit from it. So we're done, Raja, probably.
Yeah. Thank you. Thank you very much. It was
Thank you for everyone who joined to this meeting, who shared their experiences and comments and suggestions with the meeting. Cecilia, Borba, Ben, and Kian. And of course, Raja, you. I would like to thank, on behalf of Turkish neurosurgeons, to Asian Neurosurgical Society and Professor Yaku Kato, and for your effort, Raja. Hope to see you at the next webinar.
Okay, thank you. Thank you very much. It was very kind of you. So I'll wind this up now officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I'd like to thank both the speakers of today, Professor Ali Asghar Moyaidi and Professor Shuming, as well as the chairs, Prof. Cecilia Casali and Prof. Ihsan Solaroglu, for the time and support for the ACNS webinars. A very special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, we have around 924 people who have logged in through different parts of the world. Thanks to my co-host Dr. Ben from Hong Kong who joined me today, and special thanks to Professor Luis Barba for joining us today. And we hope to see you again. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.